Hello, my name is Michael Sachs, and I'm a biostatistician here at Karolinska Institutet in Sweden. I'd like to tell you about some recent work that I did with my colleagues, Aaron Gabriel and Arvid Sjölander. The paper is called Aim for Clinical Utility, Not Just Predictive Accuracy. Right now, there's a lot of hype and excitement about prognostic modeling, machine learning, and risk prediction in medicine. But how do we know when or even if a predictive model is suitable for use in clinical practice? The key is to think about what decisions the predictions can inform in the clinical context, and whether the use of the predictions to guide medical decisions leads to improved outcomes for patients. This is the concept of clinical utility. Does the use of the prediction-based decision rule in the clinical context lead to improvements in the feeling, function, or survival of patients in comparison to the current standard of care? To make this concrete, consider the example of prediction of major abdominal surgery following a Crohn's disease diagnosis. Patients predicted to be at high risk of surgery would receive combination therapy, potentially benefiting from avoiding the surgery itself. Patients predicted to be at low risk would receive monotherapy, potentially benefiting from fewer side effects. This is an example of a prediction-based decision rule. In order to assess the clinical utility of this prediction-based decision rule, ideally, we would conduct a randomized controlled trial in which subjects are enrolled and then randomized either to use the prediction-based decision rule, in which case the risk of surgery would be predicted, then low risk receives monotherapy and high risk receives combination therapy, or randomized to receive the standard of care, which may be to receive treatment according to clinician's choice. This is the ideal or target trial we would like to conduct because comparing the two randomized arms provides a direct estimate of the clinical utility. However, this may not be feasible nor timely. Instead, we could attempt to emulate this target trial using observational data. Using the same eligibility criteria and decision rule, we would try to identify patients for whom we could predict their risk of surgery at the time of diagnosis and see which treatments they actually received. In the paper, we derive an estimator for the clinical utility using observational data and show that under certain conditions, it is a valid estimator of the causal effect of the use of the prediction-based decision rule in comparison to the standard of care. In addition, observational data can be used to optimize the prediction-based decision rule for clinical utility. We provide a detailed step-by-step approach to the emulation of a target trial for a prediction-based decision rule, including R code for the estimator. As with all causal inference methods in observational studies, it relies on some strong assumptions, such as the positivity assumption and the assumption of no unmeasured confounders. In conclusion, our paper describes a conceptual framework for the evaluation of prediction-based decision rules. The key point is that using our proposed framework in observational data allows for the optimization and assessment of the benefit of using a prediction model to guide care, and thus improve patient outcomes. This has the potential to improve current medical practice in a timely manner and also to inform future randomized trials for definitive evidence. Please check out the paper in Epidemiology for more details.